Good afternoon. My name is Alexandru Achim. I'm a cardiologist from Cluj, Romania. And although I'm the last one to show you my case, I hope to catch your attention with, I would say, an interesting left main bifurcation case, which actually we did together with Gabor Tot while he visited us back in the spring in Cluj, doing this case together with the doctors from there. So the case is about a 73 years old female with the usual risk factors presenting to our service with severe unstable angina. I don't want to insist too much on the clinical data due to time constraints, so I'm going to jump right into the moving scenes of the coronary angiography, where you can already appreciate the distal left main lesion. I would say it looks like almost like a huge calcific nodule protruding inside the polygon of conference, mostly onto the left main circumflex shoulder. The proximal LAD angiographically looks very calcific, but not very tight. So I would say this is a Medina 101 lesion with a dominant circumflex and a huge left main caliber. From the cranial view, you can see that there's also lesion inside the mid LAD, and you can appreciate again the severe calcifications throughout the whole coronary system. So once again, the distal left main lesion, which actually it's like a calcific nodule, which is not very regular. It has also like a spike on top of it, which we predicted it will give us a hard time at least to wire the circumflex, if not to keep this case to a provisional strategy rather than going upfront to a two-stent strategy. So back then we thought what to do with this case. Also, I don't want to talk too much about the indication. This case was refused by the surgeon, so we had to somehow to find a solution for the PCI. Should we rotablate upfront? Can we do it only with the balloon? But if we do it with the balloons, we need a wire inside the circumflex. Can we put a wire inside the circumflex? Even if we put two wires and we start ballooning the bifurcation, we will have a huge plaque shift toward the circumflex. And is this a good idea? Can we stick to it with provisional if we do such a huge plaque shift? So in the end, we thought about going upfront rotablation with a 1.5 per and somehow stick to the provisional philosophy and strategy along the way and see if it's possible to finish with it. Like we predicted, we tried like 20 minutes to wire the circumflex. This was not possible. The operator tried various wires, various microcatheters, dual lumen microcatheter. It was not possible to wire the circumflex. The wire was always protruding inside the LAD. So in the end, we put the rota wire inside the LAD, and in our imagination, we thought about shaving at least the head of the nodule, and this way maybe we make a bit of space, and after this, the wiring of the circumflex will become a bit more easy. Unfortunately, this was right. So we could wire the circumflex after doing rota towards the LAD. This is like the final run of the rota, but I must say this took like 10 slow, good runs of rota until we obtain this result. So you really have to have patience if you want to rotablate such a huge nodule of calcium. Surprisingly, this was the result after doing only rotablation towards the LAD and towards the left circumflex. I would say this is a pretty good result, but of course you need to put higher balloons to make sure that the lesion is cracked and you can safely deploy a stent. But before that, we used IVUS in order to assess the diameter of the left main, and indeed, the proximal diameter of the left main was 7 millimeters and looked rather healthy. So we thought about not covering the whole length of the left main because of its huge diameter, but try to stick to the disease part where the plaque was and somehow land intentionally inside the plaque, or at least only a bit outside the plaque in order to not obtain a severe malapposition in the proximal left main. We did a pot with the biggest balloon we had on our shelf, which is a 6 mm balloon, which we inflated it to a maximal high pressure in order to obtain even higher diameters, to make sure that we obtain a malapposition, as this is very important. We also did kissing and then repot. Fortunately, we obtained an apposition at 6.3 millimeter, which really it's maximum. It's the maximum diameter where you can overexpand your stand. So this is the result after our pot, kiss, and repot, which angiographically and also on IVUS looked very nice. Somehow the calcific nodule almost melted, so it disappeared, and this is the benefit of rotablation, and not because of the ballooning. So this is our final result. We also stented the mid LAD. So in conclusion, what rotablation allowed us and what we learned from this case is that doing rotablation firstly allowed us to do something very basic, to wire the circumflex. It was not possible to do it without shaving our nodule. Second, it allowed us to keep our most diseased branch and as the main branch while doing our provisional technique along our PCI. Third, because we didn't balloon the bifurcation before doing the debulking, we did not have a huge plaque shift towards the circumflex where the nodule was sitting, so potentially losing it and overstretching and dissecting the bifurcation. So we really obtain a clean bifurcation by only doing debulking with the rotablation. In the end, of course, rotablation helped us to finish our strategy with just one stand, which is really great. In the end, I want to thank you, and this is how rotablation opened and kept our pathway to our provisional technique. Thank you very much.